and my friends and the colleagues here and other chairpersons. Thank you, GVK sir, for the opportunity given. I'm going to discuss another 10 to 15 minutes about non-diabetic hypoglycemia. Actually, it is very difficult to induce hypoglycemia in a so-called normal patients. If a patient develop hypoglycemia in a so-called normal patients, something is abnormal in the patient. That is what we should understand first. So, non-diabetic hypoglycemia is not at all a diagnosis. It is a manifestation of a disease, either a type 1 or type 2. In a non-diabetic, there are so many factors disease has been associated with. And essential to confirm the hypoglycemia with the Whipple's trial. We know that what is Whipple's trial. There should be a documented hypoglycemia with the sugar levels less than 70 or 60. Patients should have a symptoms of hypoglycemia, classical symptoms of adrenergic or neuroglycopenic symptoms, and patient symptoms has to be recovered by the administration of oral glucose or most probably IV glucose. That is what we classical Whipple's trial we suggest. So whenever you say a patient have a hypoglycemia, there should be a documented Whipple's trial should be there. And in a non-diabetic hypoglycemia, the proper history and blood sampling during the time of hypoglycemia, that is the most important part. So we should assess so many hormones levels and C-peptide levels. We should do the hypoglycemic testing at the time of hypoglycemia, and clinical acumen and appropriate investigation is mandatory here. So rather than going for a talk, I have 4 or 5 case studies. With the case studies, we can understand what is a non-diabetic hypoglycemia. This is a 29-year female with altered behavior disorientation in the early morning hours. For the past 2 weeks, she consulted a psychiatrist. Any clue here? And we are talking about non-diabetic hypoglycemia, correlate with that. So one day she had unconsciousness, emergency department showed blood sugar of 36. Now a clue, any diagnostic clue here? She had hypoglycemia. She is non-diabetic. She presented with altered behavior, disorientation in the early morning hours. She consulted a psychiatrist before coming to the ED department. Yes, alcohol is a good thought, sir. Alcohol will also have altered behavior, but unfortunately, this is a early morning hours only she had altered behavior. Alcohol, she is not an alcoholic, sir. She is not on any drugs. Okay, not a non-diabetic, no family history of diabetes, not on any medications, non-alcoholic. Her medical history was unremarkable. Her physical examination induced slow reaction time and slow speech, but no abnormalities in the nervous system. It is at the ED department. Vitals are stable. Blood investigation done at the time of hypoglycemia. When the patient has been come, they collected the reports. Okay. So the investigation, CBC, RFT, LFT, thyroid function test within normal levels. Plasma cortisol is in the normal range. Plasma ACTH also within the normal range. Insulin is 178 micro international units. C-peptide is quite high, 24.5. Glycosylated hemoglobin is 3.6, and antibodies are negative. Now, it is a hyperinsulinemia. It is endogenous or exogenous? How do you say endogenous? C-peptide levels are elevated. So it is obviously endogenous. To say a patient having endogenous hyperinsulinemia, what latest Harrison says that plasma insulin should be more than 3 and plasma C-peptide should be less than 0.6, plasma proinsulin more than 0.5. Unfortunately, we didn't get plasma proinsulin for this patient, and blood sugar should be less than 55. So the patient classically fits into endogenous hyperinsulinemia. So what are the causes of spontaneous hyperglycemia? Either hyperinsulinemic or hypoinsulinemic. Here we are dealing with hyperinsulinemic. So the hyperinsulinemic, here patient might be having endogenous hyperinsulinoma, non-insulinoma, autoimmune insulin syndromes, factitious hypoglycemia, alcohol, drugs. Alcohol, drugs already we have been discussed. So rest of 4 things are there. What could be the possible with the history? The classical features of insulinoma will be the patient will have a neuroglycopenic symptoms mostly without adrenergic symptoms. So this patient presented with altered behavior, mental status, particularly insulinoma will be predominant in females, that to second decade to third decade of age, 20 to 30 years of age. The patient fits in because it's a written one. Actually, it fits into the
Early morning,
mostly early morning. Fasting usually starts with early morning. Patient in the daytime they eat, so without knowing that they eat. So this patient have been insulinoma has been diagnosed. Insulinoma is a rare neuroendocrine tumor arising from the pancreatic islet cells. Incidence will be quite rare, and common age is be female preponderance and 20 to 30 years of age. More than 90% will be benign. Most of the tumors are less than 2 cm diameter, less than 10% will be malignant, and CT MRI will be diagnostic. Mostly MRI we do that, and which also detects 70 to 80%. If not able to detect, it means that patient having some nesidioblastosis. The nesidoblastoma is something islet cell hyperplasia. It is not a single tumor. Diffuse islet cell hyperplasia will also behave like this. But here we can able to find a tumor. If not able to find a tumor with MRI, we can go with the endoscopic ultrasound, selective pancreatic arterial, or intraoperative pancreatic ultrasonography will be most useful one if not able to detect one. And if it is non-operable, we can't able to detect, then we go with the drugs like diazoxide or everolimus, which is a mTOR agent. And this patient CT abdomen showed insulinoma at the tail end of pancreas, which is the commonest site, and patient has been operated while doing without hypoglycemia. This is a classical typical presentation of insulinoma in a given setup. And second case report, a 74-year-old male admitted with the hospital with the intermittent restlessness, sweating for the 1 week, sudden loss of consciousness for the past 4 hours. Patient had feeling hungry for the past 1 week, accompanied by restlessness, sweating, relief of symptoms after eating, a typical hypoglycemic symptom. At 1 a.m. of the day, patient at hospital admission, the patient felt dizzy. 7 a.m. patient found unconscious, unable to respond, the urinary fecal incontinence. Upon admission, patient HbA blood sugar was 42 and recovered with 25% of dextrose. So he is not non-diabetic, no family history, not on any medication, non-alcoholic, poor intake for the past 2 weeks. Her physical examination, bloated abdomen, no tenderness and no septic dullness. Okay, and no ascites, even though bloated abdomen. And investigation, CBC, RFT, LFT within normal range, plasma cortisol normal, plasma adenocortical symptoms are normal, insulin also normal, 2.5 within the reference range, C-peptide also quite low, 0.4, and glycosylated hemoglobin is 0.6, antibody is also negative. So it is hyperinsulinemic or hypoinsulinemic hypoglycemia. Obviously hypoinsulinemic hypoglycemia. We come across the same slide again. This is hypoinsulinemic hypoglycemia. What are the causes? Either may be critical illness, sepsis, cardiac failure, malaria, endocrinopathies, hypotension, hypopituitarism, non-islet cell hyperglycemia, mesenchymal tumors, and some inherited metabolic conditions. And unfortunately, this patient had hepatocellular carcinoma. Why hepatocellular carcinoma causing hypoglycemia? Glucose production may be low, and most possible explanation, the actual explanation will be it's a paraneoplastic syndrome, particularly IGF-2. So mesenchymal tumors and hepatocellular carcinoma will produce insulin-like growth factor 2, which is a big factor tumor marker, which is a big IGF-2, which binds to insulin receptors, which increases glucose uptake in the peripheral tissues. And whenever the diagnostic marker will be IGF-2 to IGF-1, levels will be deranged. IGF-2 induces hypoglycemia by reducing hepatic glucose output, increasing peripheral glucose uptake, inhibits lipolysis, ketogenesis. Hypoglycemia suppresses pancreatic beta secretion. Hypoglycemia with suppressed insulin, C-peptide, inappropriate low growth hormone. So not only insulin and C-peptide will be low, growth hormone levels also be low. So in a older age patient, so-called normal admitted with cachextic symptoms with hypoglycemia, think of some tumor, particularly mesenchymal tumor or some other hepatocellular carcinoma, think of IGF-2. And the case report 3, a 55-year male admitted with ICU because of severe pain, fever, swelling of right leg for the past 1 week, sudden loss of consciousness for the past 4 hours. The patient diagnosed with leg cellulitis with sepsis. Upon admission to emergency department, patient blood sugar was 56, recovered unconscious state with 25% of dextrose. Patient persistent hypoglycemia in the ICU, which requires continuous infusion of 25% dextrose. So clinical examination, not a non-diabetic, no family history, not on any medication. He is an alcoholic, fever and severe leg pain, classical cellulitis with septicemia. Physical examination, altered mental status and hypotension, tachycardia, tachypnea is present, and investigation CBC, RFT, leukocytosis, altered LFT, elevated renal function test, classical sepsis features. Plasma cortisol is low, plasma adrenocorticocortisone levels also low, insulin is low level 1.8, C-peptide is 0.45, glycosylated hemoglobin 5.6, antibodies are negative. This is also hypo or hyperinsulinemic? Hypoinsulinemic. So which category he fits in? Critical illness. Critical illness, which category comes in? Impairment. How can sepsis? We know that whenever there is an infection, we know that there is a hyperglycemia. Can sepsis cause hypoglycemia? Sepsis per se can cause hypoglycemia. So sepsis is a cause here. Sepsis associated hypoglycemia. Hypoglycemia is not a typical manifestation of sepsis. If present, it has, meaning that it has a poor prognosis. While hyperglycemia more common in sepsis, severe sepsis and severe acidosis usually associated with it, commonly with streptococcal pneumonia, Haemophilus influenza infection. Any infection, particularly Pseudomonas, all these infection can cause hypoglycemia. How sepsis cause hypoglycemia? Increased glucose utilization in macrophages, particularly in the liver, spleen and the lung. So macrophages eats more glucose, and cytokine induced inhibition of gluconeogenesis, there is no production of glucose, and lack of cortisol. Because of sepsis, there is a hypoperfusion in the adrenal gland also, so cortisol levels will not be much elevated as expected, and hepatic renal hypoperfusion further add on to the scenario. So the sepsis diagnosed here. And the case report 4 is 49-year-old female came to OPD with complaints of increased sweating, palpitations, tremors. Symptoms were relieved after eating food. This is a classical, typical we think of hypoglycemia. She is not a non-diabetic, no family history, not on any medications, not alcoholic. She has regular menstrual cycle. There is nothing to do with postmenopausal syndromes. And her physical examination is insignificant. Vitals are stable. Investigation suggests random blood sugar is 112, CBC, RFT, LFT is normal, plasma cortisol normal, insulin levels are normal, C-peptide normal, HbA1c 5.2, antibodies all normal. So normal patients presented with symptoms of, classical symptoms of hypoglycemia. How to proceed further? Ranjit pointed out how to diagnose hypoglycemia. This is so-called normal. Patient symptom, classical symptoms of hypoglycemia. Can we normal blood sugar during symptomatic episode? So doesn't fit in the category of anything else. Patient not having hypoglycemia, but symptoms classically presents as a hypoglycemia. Whether to go with GTT or mixed meal. The classical teaching previously when I was post-graduation days, we teach usually informed us extended GT has to be done, but nowadays extended GT has been given up because of normal healthy patients. Extended GT will have a false positive low, so it is not usually done. The mixed meal will be the recommended therapy. The mixed meal test, fasting is 98, second hour is 114, fasting C-peptide is 0.5, second hour C-peptide is 2.5, 3.5, it's classical normal. This is not a hypoglycemic. What else? What else classically behave the symptoms of hypoglycemia? Adrenergic symptoms, what will happen in adrenergic symptoms? Which disease will have? Anxiety neurosis. So not all hypoglycemia are true hypoglycemia. And if the scenario comes like this, fasting is 98, postprandial is 82, fasting C-peptide is 1.1, second hour is 8.5. This normally come across. Postprandial is lower than the fasting, but both are within the normal range. Reactive, usually they have a diabetic. Even in pre-diabetes, we don't call pre-diabetes, even before diabetes, sometimes it can occur. If you pick it up at this stage, we should educate patients for lifestyle modification. We can prevent pre-diabetes also. We know that first phase and second phase insulin secretion, and in this group of patients, this second phase insulin secretion is extended and prolonged because of hyperinsulin resistance, and some mild hyperinsulinemia will be there. So this group of patients will have hypo symptoms just before lunch, even though they so called normal. So if you are able to pick, if you come across a patient with fasting is just above the postprandial, advise them to go for lifestyle modification to prevent diabetes. This is not normal, we have to educate them. So non-diabetic hypoglycemia classified as hyperinsulinemic, hypoinsulinemic, and some inborn errors which is common in pediatric age group, either with the fasting, disorders of glycogenolysis, postprandial would be congenital disorders of glycation, some exercise induced, some beta cell increased activity of monocarboxylase also be present. So a list of drugs we have to rule out. If a patient had a history of drugs, we have to rule out list of drugs, particularly anti-malaria drugs and gatifloxin. That is why the gatifloxin has been withdrawn from the market because of dysglycemia. And approach to non-diabetic, we have to rule out whether patient have hypoglycemia or not. Once patient had hypoglycemia, we have to elicit that whether it is hyperinsulinemic or hypoinsulinemic. Once it is hyperinsulinemic, look for C-peptide, whether it is exogenous or endogenous. Accordingly, we can diagnose the patient. To summarize, hypoglycemia is a non-diagnosis, but it is a manifestation of disease. Hypoglycemia is rare in non-diabetic individuals. Essential to confirm hypoglycemia with Whipple's trial. Proper history and blood sample during hypoglycemia is mandatory. Clinical acumen, appropriate investigation is mandatory for optimal management of hypoglycemia. Thank you for patient listening.
Thank you, Dr.